I'd like to introduce Dr. Elliot Israel as the first speaker to give his thoughts about how he would approach this patient. Dr. Israel.
Thanks so much, Chris. It's really a pleasure to be here, and I've been asked to take the position regarding this patient in terms of increasing the dose of inhaled corticosteroids. So as presented by Chris, the question was the next step, whether to increase the dose of inhaled corticosteroids or add a long-acting beta-agonist. And I'm going to take the position that we should increase the inhaled corticosteroids. So what are the pros? What are the reasons that we might think about increasing the dose of inhaled corticosteroids? We know that inhaled corticosteroids suppress any additional uncontrolled inflammation, and we're not introducing another medication. And we also know that inhaled corticosteroids prevent deaths in asthma, and that prevention and the association of prevention is directly related to the amount of inhaled corticosteroid used. And as you increase the amount of inhaled corticosteroids, you decrease the deaths associated with asthma. So there are reasons to think about using inhaled corticosteroids. There are also reasons to think about not using inhaled corticosteroids. Inhaled corticosteroids, as we'll talk about, have a somewhat flat efficacy dose-response curve, meaning that they tend to plateau, and increasing the dose of inhaled corticosteroids actually, rather than increasing the effect and the improvement, actually seems to perhaps have a linear effect in terms of the side effects. And actually, data that we've published actually showed that if one looked at the dose of inhaled corticosteroids in premenopausal women, and followed them over 3 years, one found that there was a linear association between a small decline in bone density and increasing doses of inhaled corticosteroids. So there is this linear issue regarding to increasing the dose of inhaled corticosteroids. So it's not totally free. So, and also, don't we believe, and haven't we been told, that increasing the dose of inhaled corticosteroids is less effective than using a long-acting beta-agonist? So if we've got a kind of flattish dose-response curve, and if we think that there's a linear increase in our side effects, why would we really think about using inhaled corticosteroids? Well, let me re-examine the issue and the question of whether increasing the dose of inhaled corticosteroids is really less effective than a long-acting beta-agonist. And where this really started, it was a study back in 1994 from Greening in England, where they took patients who were symptomatic on beclomethasone 200 twice a day, and they randomized them to salmeterol 50 micrograms twice a day and budesonide and beclomethasone 200 BID, or increase their dose of beclomethasone to 500 BID. And they showed, as expected, that there was an increase in pulmonary function. You're using a long-acting beta-agonist, you're certainly going to see an increase in pulmonary function. What they also showed, which has convinced a lot of people that we should be thinking about increasing the dose of LABA rather than increasing the dose of inhaled corticosteroids, was that there were differences in terms of nighttime and daytime symptoms in the patients when they were taking this. This is week 1, week 7, and week 13 and week 21 of these patients. And looking at nighttime symptoms, you can see that and this is a decrease in nighttime symptoms, a decrease in daytime symptoms. The black lines represent the salmeterol, beclomethasone. The white lines represent the beclomethasone alone. And what you can see is that it appears that the salmeterol beclomethasone was more effective in reducing the nighttime and daytime symptoms. What got ignored in this article was that when one looks at what we now consider the more important way and the more usual way to now think about symptoms, the percent of days with symptoms or without symptoms actually was decreased pretty equivalently by using inhaled corticosteroids and using LABA. So both groups started with about 87% of their days with symptoms, and after being in the study at the end of 13 weeks, the salmeterol beclomethasone group had reduced to 56% of their days with symptoms, and the beclomethasone group alone had reduced to 61%. Not a significant difference, both of them significantly different than they were in the beginning. So when we actually uses what we think now of as a better way of thinking about symptoms, there really wasn't a difference between inhaled corticosteroids and salmeterol. What there was and what there has been, and it has been shown in multiple studies, is a significant difference between the effects of adding a LABA and adding inhaled corticosteroids on exacerbations. And this is from the FACET study, which we'll come back to again a little bit later, where they looked at patients who are on beclomethasone 100 micrograms a day, and then or patients who are on 100 micrograms of beclomethasone plus formoterol, or 400 micrograms of formoterol. And this is the rates of exacerbations, or the number of patients per year had exacerbations. And you can see that adding the inhaled corticosteroids was significantly more effective than leaving them, or increasing the dose of inhaled corticosteroids was significantly more effective than leaving them on the lower dose of inhaled corticosteroids, and was significantly more effective than adding salmeterol, although, as I'll show you later, these patients symptomatically said that they felt just as well on both regimens, but exacerbations were not as well controlled. And a really more interesting study is the GOAL study. This is a one-year randomized, double-blind, parallel group study that was done in over 1,000 patients, and they took 3 stratas of patients based on inhaled corticosteroid use. Stratum 1, patients who weren't on corticosteroids. Stratum 2, patients who were on less than 500 micrograms. And Stratum 3, patients who were on 500 to 1,000 micrograms. And what they did is they increased the doses of inhaled corticosteroids or inhaled corticosteroids plus salmeterol in these patients. So what they did is they took them up to step 1, where they increased the dose, if you hadn't been on inhaled corticosteroids, to fluticasone 100 or fluticasone 100 plus salmeterol. If you weren't controlled at the end of 8 weeks, they went up to fluticasone 250 or fluticasone 250 plus salmeterol, depending on which arm you had been in. And if you still weren't controlled after 8 weeks, they took you up to fluticasone 500 or fluticasone 500 plus salmeterol. And they talked about people being well controlled. I'm not going to spend time going through this, but they had a well-accepted definition of well controlled. And so the data, as had been interpreted, was that in every case, salmeterol plus fluticasone was better than fluticasone. And that's true. If you took people on 100 of fluticasone and added salmeterol, they were better when they were on 100 of fluticasone plus salmeterol. But the question we're asking is, should we move up on the inhaled corticosteroids, or should we add the salmeterol? And this is what it looked like when you actually look at stratum 1, stratum 2, and stratum 3. Remember, no inhaled corticosteroids, less than 500 or greater than 500. And so here on these pink ones are the fluticasone salmeterol groups, and here on these yellow ones, or orange ones, are the fluticasone alone. So here's fluticasone salmeterol at the lowest dose, and here's the percent of patients who are well controlled on fluticasone at the second dose. You can see that in the case of patients who weren't on inhaled corticosteroid, actually being on a higher dose of inhaled corticosteroids was actually more effective than being on fluticasone salmeterol. Okay, let's look at stratum 2. Stratum 2, again, increasing the dose of inhaled corticosteroids versus having added the salmeterol onto the low-dose fluticasone, no difference between the two. And let's look at stratum 3. Once again, no difference between the two. You did just as well increasing the dose of inhaled corticosteroids as you did adding salmeterol. And then let's look back at the FACET study, and this is, I think, part of what confuses us. So look at the FACET study. Remember, in the FACET study, if you went on to lower dose budesonide plus formoterol versus higher dose budesonide without formoterol, you had a decrease in your exacerbations. But look at the symptoms. The symptoms were really pretty equivalent. But salmeterol does help control symptoms, but probably around the same range as inhaled corticosteroids. So what I conclude from these studies, it's really not clear that adding a LABA is significantly more effective than increasing the inhaled corticosteroids in terms of symptom control. And it does appear, and it's clear actually, that it's less effective in terms of controlling exacerbations. And if you don't believe me, these are the specific label changes that the FDA has recently required for LABAs. It talked about contraindicating the use of LABAs in patients of all ages without concomitant use of an asthma controller medication such as an inhaled corticosteroid. And it suggested stopping the use of LABAs if possible once asthma control is achieved and maintain the use of an asthma controller medication such as an inhaled corticosteroid. And it recommended against LABA use in patients whose asthma is adequately controlled with a low or medium dose of inhaled corticosteroid. This patient was on a low dose, and so the FDA is suggesting, based on its analysis, that you should go into medium. What's the rationale? What's the FDA concerned about? There are a few things. And again, I'm quoting from the FDA. Benefits shown in studies for combination products are largely a measure of the beta-agonist effect, such as improved airflow and reduced use of SABAs. No studies showing that LABAs alone or in conjunction with inhaled corticosteroids increase survival or positively affect severe asthma exacerbation. And the clear benefits of inhaled corticosteroids in patients with asthma, they have not been associated with serious adverse outcomes. The FDA believes it's prudent to emphasize their use and limit the long-term use of LABAs. What's the FDA concerned about? There are multiple studies that suggest there's decreased bronchoprotection after regular use, after exercise, allergen, methacholine, and AMP. We've just completed a study where we took patients and exercised them, and after 2 weeks of use of salmeterol, their bronchoprotection from exercise was completely lost, and a third of the patients actually were worse in terms of their exercise. The effect was not prevented by inhaled corticosteroids. There's a decreased response to beta-agonists, and there's increased evidence of inflammation during exacerbations. And this is a study that was done by the ACRN, where we had first set the outcome for adding salmeterol into inhaled corticosteroids to FEV1. What we found was salmeterol improved the FEV1, but when we looked at exacerbations, the salmeterol could not substitute for inhaled corticosteroids. This is the study by Castle that set off the whole question about whether there would increase deaths, respiratory-related deaths related to the use of salmeterol. And the Castle study, 75% of the patients were using inhaled corticosteroids. And then lastly, this is actually an analysis by the FDA where it looked at the use of inhaled corticosteroids and Formoterol in placebo-controlled studies, and there were more serious adverse events related to use of Formoterol despite inhaled corticosteroid use. So if you look here, Formoterol at any dose, 20 micrograms or 48 micrograms, the rates of exacerbations relative to 1 for the patients who were not on Formoterol, these are Formoterol and inhaled corticosteroids, were fourfold greater. 3.5 for the 20 to 24 microgram, 5.6 for the 48 microgram, as compared to 0.9 with placebo. So a 4 to 5-fold increase in serious adverse events related to the use of Formoterol. So conclusions. LABAs decrease symptoms. They prevent exacerbations related symptoms. They may have less effect on exacerbations, leading to hospitalizations and or death. There appears to be an idiosyncratic effect of severe asthma deteriorations associated with LABA use, possibly even in the setting of inhaled corticosteroids. The absolute risk most likely varies based on underlying asthma control and appears to increase with age, and it may vary by as much as 1 to 1,000 to 1 in 20,000. So my conclusion, increasing the dose of inhaled corticosteroids will generally achieve symptom control equivalent to adding a LABA, despite what you've been told. It will provide greater protection exacerbations. Nobody questions that. So the next step for this patient who's on a small dose of inhaled corticosteroids should be going to a moderate dose of inhaled corticosteroids. Thank you very much.